And for those of you who just joined, this is Dr. Suzette Sutherland. She is the Director of Female Urology at the University of Washington and an Associate Professor of Urology, and she'll be talking about female urinary incontinence.
Great. Thank you very much for that introduction and the opportunity to speak today. I'm really thrilled to be able to do this, and for our urological colleagues over in Ghana. I do some work in Senegal, predominantly Dakar and the surrounding area. So I'm very well versed in the environments that are there, and also the differences in training patterns as well as practice patterns, and some of the things that we have access to here in the United States that you may not have access to. So my lecture today is going to be talking about female urinary incontinence and looking at the evaluation and treatment thereof. And then also, even though some of the new innovative things aren't available in Africa right now, and some not available here either, they're under development, but I think it's important for you to also hear some of the technological advances that are happening in our field and where we're going with this. So these are my disclosures. I am an investigator in many different multi-center trials dealing with some newer technology in this area. And this for you all the way on the other side of the world who don't know what Seattle is all about, that's where I'm from, Seattle, Washington. So Washington, the state, way up in the northwest aspect of the United States, so very far from Africa. These are some highlights of Seattle. This is our famous Space Needle here. That's sort of what people really know us for. If you ever see any skylines of Seattle, that's what you will see. Our medical center at the University of Washington over here is on our campus, an absolutely gorgeous, large University of Washington campus, for which that W stands for. Here is our Husky Stadium overlooking Lake Washington, beautiful. We're of course known for our Seattle Seahawks, the football team, and then just water everywhere, our sound. We're not far from the ocean, but we have ferries going out to the islands, and here's the snow-capped mountains in the background and Mount Rainier. Our Seattle Sounders is our soccer team, which we're very fond of. Soccer is a big sport here in the Pacific Northwest. And then we're also well known for our public market center, Pikes Market. Everyone, all the tourists have to go there. So if you come, these are some of the things that you will be able to see. It's very beautiful here. Oh. So with that, we'll look at the outline here. We'll talk about the evaluation and treatment of urinary incontinence, and specifically the two main kinds: overactive bladder, urgency urinary incontinence versus stress urinary incontinence, and then look at the new technologies and clinical trials. So this slide, I love this slide. It's a reminder for me to say that, it's not a life or death situation, urinary incontinence. We know that. It's a quality of life issue, but it is a big one. And there's never a happier patient than when you get her out of diapers and dry, and she can be active in the things that she wants to do. Because as this poster here says, because life's greatest adventure shouldn't be finding a bathroom. We have way more better, important things to do with our time. So again, not all incontinence is the same, and identifying what type of incontinence the woman has, that's really the key to identifying what the right treatment algorithm is for her. The main two are stress urinary incontinence. I cough, I sneeze, jump up and down, strain, and a little bit of urine squirts out. Stress, physical stress, not emotional stress. So that's usually associated with an anatomical weakness about the urethra, bladder, or the pelvic floor muscles. The woman's not strong enough down below and can't overcome that Valsalva maneuver, and the urine squeezes out. The next one is urge incontinence, or overactive bladder, OAB. I gotta go, I'm going frequently, and oh my gosh, I have to go so badly. It's such a strong urge, I can't make it, and it just starts coming out. Sometimes a little dribbling as you're running to the bathroom, and other times it can be a big flood. You just couldn't control it. We think of that more as a bladder function problem. Something's wrong with the bladder that's not appropriately responding to signals to stay quiet, and sometimes has a mind of its own and contracts against your will. And then with that contraction, it causes an increased pressure in the bladder, which causes that urge, and then you can't overcome it, and it just comes out. Mixed incontinence is defined as the combination of both of those two things. And this is a lot of the patients that I see, many of them have mixed incontinence. And I'm at a very large referral center, so that's the reason. And the important thing is for the provider to identify that there are two problems going on, but also to educate the patient that there are two problems going on. Because as we go through the treatment algorithm, you'll see the treatments for these two problems are very different. Overflow incontinence, that can happen as well. Incomplete bladder emptying, the bladder maybe is very full and not able to get much out and always just dribbling a little bit over the top. Not very common in women, can be there if there's something wrong with the urethra, a true urethral stricture, which isn't very common in women, or something pushing on the urethra. We see that, of course, more commonly in men as the prostate enlarges with BPH as they age and have more and more trouble emptying the bladder. But it can be seen in women too and needs to be ruled out. And then continuous incontinence. There, of course, we're talking about just the constant dripping out. There's no provocative thing. There's no urge. There's nothing. And we're thinking about an abnormal communication between the bladder and something else that it's just coming out, usually the vagina. And that we're thinking about most predominantly a fistula. So this picture again brings home the point, the difference between that urge incontinence and stress incontinence. We have for the urge incontinence, we have these little red arrows here that are showing that the bladder is the problem, is contracting and squeezing on the bladder, the volume in the bladder, causing that urge and the urine comes out. Whereas stress incontinence are the green arrows, and it's an external force that's actually pushing on the bladder. It's not the bladder itself contracting, it's the push on the bladder. And the patient isn't strong enough down below here in this pelvic floor muscles in order to overcome that force that's pushing against it. So again, urge is a bladder issue. We need to get the bladder to calm down in order to be able to hold more and not have that leakage. And the stress incontinence is a pelvic support issue by and large in any case. And it's about recreating the support from down below. Again, so we'll start by talking about the overactive bladder urgency incontinence evaluation and treatment first. So OAB, it's really defined as a clinical syndrome. Urgency, urinary frequency, nocturia, getting up at night, and urgency incontinence. It can be one of these, a combination, or all of them. And the key here is that it has to be in the absence of other obvious processes that could be irritating the bladder. It's nice to think about these underneath a big umbrella of calling it irritative voiding symptoms. And if there's something irritating the bladder, well, we know the bladder responds by just saying, I need to get this out. I need to go to the bathroom, and maybe it contracts and has a spasm to try and get whatever is irritating it out. That could be the differential list down here, a urinary tract infection. It could be a bladder pathology, a tumor or a stone in the bladder, or it could be something like prolapse. The bladder is falling out and it's causing a lot of pressure on that bladder, making it feel like it's full, or a mass pushing on the bladder, whether it's an enlarged uterine fibroid or something else. And then it could be some other medical things such as diabetes insipidus or polydipsia. But we need to rule those things out though before we move on and just call it overactive bladder. So what is normal voiding? So we want to look at the number of voids per day, the number of nighttime getting up, interrupting the sleep, and then the 24-hour number of voids per day. And normal is usually up to about 7 voids per waking hours relative to, and it's all though relative to the perception of normal for the patient, whether we call it really overactive bladder or not. It needs to be bothersome to the patient. But when we think about normal voiding, normal is about every 3 to 4 hours during the day. So somewhere between 5, maybe 7 for the course of the 24 hours. And getting up once is permissible per the AUA guidelines. So we say anything over 9 voids or more puts you in the category of overactive bladder. Here the AUA SUFU 2019 guidelines for the evaluation and treatment. This is an OAB clinical care pathway, which you can get. There's an AUA app with all of the guidelines that are on there, and it has these flow sheets for a variety of things. So there's a whole bunch of things. So if you don't have that app, it's nice, handy to download that and use this. So this is the American Urological Association and the Society of Urodynamics, Female Pelvic Medicine, and Genital Urinary Reconstruction. That's what SUFU stands for. They got together to put these clinical guidelines together. So the first things, of course, are the evaluation, and that's what we're going to talk about here today, right next. So here's a summary of it, really. What they say for the evaluation that's mandatory is a good history, focused pelvic exam, especially in the pelvic area, or focused physical exam, I mean, especially in the pelvic area, and then a urine analysis. Those three things are really the bulk of the mandatory workup for overactive bladder. Other things that are helpful before initiating therapy are during post-void residual, a fluid diary, and these other things really are not indicated for the initial evaluation of somebody with overactive bladder. Doing fancy urodynamics, doing cystoscopy, or any upper tract imaging, it's really not needed for the standard patient. So let's take a look at these. So the first thing is the history. When you ask the right questions, by and large, 90% of the time, you can figure out what's going on with the patient with respect to her incontinence. If it's overactive bladder, urgency, frequency, right? Or only happening with a stress maneuver. Is she really having difficulty emptying her bladder? Does she have hesitancy, a low stream? Or does she always have that nagging feeling like she still has a little to go and she says, I push, but I just push to get the last drops out? That's usually somebody who truly does empty. They just have this irritative, nagging feeling like they're not empty, but functionally they are emptying. We want to look at their fluid intake habits, dietary choices, of course, that can influence the voiding, and then any medications, and of course the bother factor. How much is it bothering them? We look for comorbid conditions that could also influence a voiding pattern, right? Neurological problems, mobility issues, concomitant bowel issues. People who are constipated, it makes their bladder symptoms worse, especially with respect to overactive bladder, and a list of other things that are listed there. The components of a focused pelvic exam are listed here. And the main things are, it states digital rectal exam first. I like to put that at the bottom because that's the order in which we do things. We do the pelvic exam, we look at the external genitalia, make sure there's nothing wrong there, the urethral meatus, the urethra itself, feel under the urethra, no diverticuli, no scarring. Then we look at the bladder. Is there any tenderness? Does it feel full that she just went to the bathroom? Then the bulk of it is what we're doing is looking in the vagina. And predominantly here, you can see we're looking for the estrogen effect in the vaginal canal is ever so important. Are there any signs of infection or problem or lesions? But then what's that pelvic support like? Does she have a cystocele? Does she have a rectocele? Is the apex of the vagina well supported, whether she has her cervix or not, and uterus or not? And then doing a bimanual exam, feeling the cervix, uterus, is there anything bulky there? Adnexa if you can, looking around the perineum, and then do the digital rectal exam, looking at the quality of the sphincter, and are there any other masses that you feel? So this is really important to do this focused pelvic exam in anybody that's coming into your office with really complaints of urinary incontinence before trying any treatment. The next mandatory thing was a urine analysis. So what are we doing? We're ruling out, of course, a UTI. We're also ruling out any blood in the urine that might indicate there's something else in the bladder, such as a tumor or a stone. And blood in the urine is 3 or greater red blood cells per high-powered field collected on an appropriate sample. Urine culture? Well, only in a response to a UA. If the UA looks like it's dirty and it looks like it might be infected, then go ahead and send it on for culture, but otherwise not as a routine thing. It should be only reflexive, and that's a big point. So many times people just automatically send it and it's a waste of money. If the UA is clear, the urine culture will be clear. So additional procedures besides the urine culture would be, again, a post-void residual. I strongly feel that a post-void residual is very helpful in these patients. because somebody can go to the bathroom into a stall every hour, let's say, and they're peeing a small amount, and another person in the bathroom stall next to her can be going every hour and she's peeing a small amount. But this one is responding to an irritative bladder. She doesn't have very much in her bladder each time she goes, but she has such a strong urge, she just can't suppress it. And she goes and she empties and does empty, but she just doesn't have much to work with. This person over here has a neurogenic bladder maybe, or a floppy bladder, not able to empty her bladder. She goes in and she just squirts a little bit out each time, the same amount. But the reason she's going so often is because her bladder is really very full and she just can't empty. So those are very different patients, right? And so our treatment for patient number one is get her bladder to calm down, that irritative symptoms to calm down so she can hold more. Over here, it's about getting her to empty her bladder better, whether she can do it herself or she needs a catheter or something. So I really strongly feel that it's an important part of the evaluation, although the AUA SUFU guidelines did not put it in the mandatory category, but acknowledges that it can be very helpful. And then the other is bladder diaries can be very helpful, but if you do them, you want to time not only the voids, but how much they're peeing, what the volume is that they're drinking and what the volume is that's going out with each void. At what bladder volume are they inspired to go? That's really helpful. And then validated symptom questionnaires can be helpful if you feel that you still need those. Complicated or refractory overactive bladder patients, these are the ones where you consider urodynamic cystoscopy or a bladder ultrasound. So patients who have a neurogenic component, or they do have outflow issues or obstruction, they're not emptying their bladder such they're leaving 100, 200 behind every time they void. They've had prior surgeries, or it's really difficult to distinguish when based on the history and physical, what's really going on. Maybe they're a poor historian and it's hard to get a good history. Or you've tried a number of treatments and it doesn't make sense, they've failed and it just doesn't make sense, then there's something missing. So doing further testing is helpful to identify what's going on with the patient. So again, the mandatory is to do a history, a physical exam focused on the pelvic area, and a UA. What's helpful is a post-void residual assessment, fluid diaries. And for the straightforward index patient that walks into your office and says, thinks they have overactive bladder symptoms, you don't need to do urodynamic cystoscopy or any imaging. That's for patients who are a little more complicated. So here's our clinical care pathway again. We just talked about the evaluation. Now we'll move into the treatment options. So for the treatment options, they're broken up into, well, we think four main groups, but the first three are really based on risk. The first line therapy has no risk to it whatsoever. It's about patient education, behavioral treatments. The second line therapy is pharmacological therapies. So it's non-invasive, but there are risks of side effects associated with it. And then the third line therapy, if they don't respond to first and second line therapy, we call that refractory overactive bladder, or ROBI. And then there are third line therapies that we have to be able to offer to them, at least here in the United States. I understand that not in Africa. They do require a referral to a urologist for sure to do these, and a specialist who specializes in these things, but there is associated risk with these. They're all procedures of one sort or another. So let's take a look at the first line therapies. Here's really where we need to do a lot of education with the patients, and they have to understand things that they're doing that are influencing their symptoms. So we educate them, of course, about normal bladder function. Many times they don't even know what's normal. How many times should I be going to the bathroom and how much? We want them to modify their voiding habits by doing some bladder retraining. Many women have been doing the same thing for so many years. It's just a habit all the time. And they realize, wow, I didn't really respond to an urge to go. I just went because I thought I was supposed to, or as a habit. And so they need to recognize what's normal and try to emulate that normal pattern when they can without it leading to incontinence. Oftentimes it's about delayed voiding. Sometimes it's about voiding more often. Pelvic floor muscle training. This is really important. That's getting those muscles in the pelvic floor stronger. That's that Kegel exercise. You're familiar with that. when women are doing a Kegel exercise appropriately, they're not only squeezing the muscles that you want to squeeze when you want to stop from voiding, urinating, but you're also squeezing the muscles you want to stop from passing gas from behind. So you're squeezing the front and the back. Both of those together are appropriate Kegel exercise. And when you squeeze the back end as well, you get a bit of an upward lift with that squeeze. And that's really what's supporting that whole pelvic floor. So it's all about strengthening. But we also use Kegel exercises for what's called urge suppression. When you feel that strong urge to go, and you might even have an abnormal bladder contraction that's documented on a urodynamic test, and you engage those pelvic floor muscles nice and tight, it sends a reflex message up to the bladder that says, hey, the door's closed down below, knock it off, and the bladder then relaxes, and that contraction goes away, so ergo the urge goes away, and then the patient can hopefully make it to the bathroom without leaking, or maybe even postpone going if they know they're not really full. So that's called urge suppression. And we teach patients how to do that. If it's a little more complicated situation, we often send them to the pelvic floor physical therapist. We have plenty of those here at University of Washington who specialize in this area, and thank God for them. They do tremendous work. And it really is about looking at the entire pelvic area functionally as a whole, and how it attaches to the hips, to the sacrum, to the SI joints, to the pubic bone, and all of that needs to be appropriate for things to work well. Then other things, of course, fluid management, we already touched on a bit, and then weight loss can be beneficial as well. So these are really modifiable things that the patient can really do. If that's not working, then we move on to second line therapy. Second line therapy are the medications. And here's a long laundry list of the medications that are available. And I highlighted the ones that I understand to be available for you in Africa. So the first category are the anticholinergic medications, and they work by blocking the receptors to the M2, M3, so that it causes relaxation of the bladder. Oxybutynin has been around a long time. It comes in a short-acting formulary, for which you're supposed to take it 2 to 3 times a day in order for it to work. Because otherwise, if you take it just once, it wears off after about 8 hours, and then you're not covered for the rest of the day and night. And you take it again in the morning, and you might feel good during the morning hours, but then not in the afternoon, evening, or night. So the long acting, though, is a 24-hour drug. And so you only take it once in the morning, and it lasts 24 hours. The other one that is available, solifenacin, that it works just as well as the oxybutynin in appreciable doses. And then I understand you have imipramine. Imipramine, as you may know, is an antidepressant, an anticyclic antidepressant, or tricyclic antidepressant, I'm sorry, but it has an anticholinergic component to it, and that's how it works for the bladder as well. It does have a bit of a quieting agent to it, so it's best for patients, for the most part, to take it in the evenings, and it helps for patients who have more problems at night with getting up at night, and it helps them sleep as well as calm that bladder down. Other ones on this list that you don't have, which is worth pointing out, is trospium chloride. Trospium chloride, although it's an anticholinergic medication, its chemical molecule is different such that it does not cross the blood-brain barrier. It doesn't get into the brain. All of these other ones do. And oxybutynin, we know, is a very small molecule, and it crosses into the brain most when you look at pharmacokinetics than compared to the other drugs, but the other drugs go into the brain as well. But the trospium chloride does not. And so with that, there's no risk of cognitive impairment or dementia. There's a big issue now with thoughts about people being on anticholinergics for a long period of time, and does it contribute in the elderly to development of dementia? And so there are many patients who don't want to be on these drugs anymore. So that's the advantage of the trospium chloride, that there's no risk of dementia. And then the next category are the beta-3 agonists. They're the new ones on the block, so to speak, the mirabegron. And now a very new one that was just FDA approved was vibegron. Both of them, they They do the same thing as far as getting the bladder to relax, but they do it in a different mechanism of action. They don't have all of the side effects that the anticholinergics do. I didn't mention what those were, but those side effects, besides the concern for dementia, are dry mouth, dry eyes, sometimes with that blurred vision, and constipation. Those are the main side effects, anticholinergic. The sympathomimetics, they don't cause any of those side effects. With mirabegron, the one thing is it may cause some issues with blood pressure, high blood pressure, so you need to check their blood pressure, but predominantly in patients who already have high blood pressure, it may be difficult to control, and then it makes it difficult to control again. So it doesn't give somebody de novo hypertension, at least we've never seen that. And vibegron, the newest kid on the block, doesn't have any issues with high blood pressure. So thus far, it looks like it's not really associated with any significant side effects. When we look at the AUA SUFU guidelines and look at all of the studies, the FDA approval trials and all that look at comparing these agents, there's no compelling evidence for any differential efficacy between any of these at appreciable doses. So in other words, there's no one standout here that works better than any of the others. That's why there's so many there on the market. The only advantage, I would say, of the beta-3 agonists is the lack of anticholinergic side effects. Unfortunately for us, even, they're very expensive. Many patients can't get them. So I don't know if they are at all available in Africa and at what point they might be. But I think they're a game changer if they are accessible. The guidelines recommend too to try an extended release drug first if you can, if their insurance will allow. Of course, for us, that's what the issue is, because with the extended release, they get an even steady state in their bloodstream of the drug, as opposed to these peaks and valleys that happen with the intermittent agents. So the short acting versus the long acting. And then you get less side effects associated with that, just even steady state as well. And the other big recommendation was, if you start somebody on a drug and you don't really notice much as an effect, don't throw it away. Just say, okay, maybe they need a higher dose, and titrate up the dose. If it becomes a point where they can't tolerate it because of side effects, well, then you move on to a different agent. But I see that all the time. People started on a very low dose of oxybutynin, they didn't respond to a 5 milligram tablet, and then they say they didn't respond, so they move on to a different agent. But 5 milligrams is a tiny little dose. If you know, you can titrate up to 30 milligrams a day with the oxybutynin. And I think an adult starting dose is usually around 10. And then also think about combination therapy. People are doing that here in the United States a little bit more, putting them on an anticholinergic, but at a smaller dose, and then adding a beta-3 agonist to it to get more efficacy for the bladder, but without getting the high anticholinergic side effects. So that's being done here in the United States to some degree. I'm not a big fan of that because it gets into polypharmacy. Patients are on so many medications, but I have had some patients who've responded nicely to that and wanted to continue. So if they're not responding to the behavioral things as well as now the medications, they're still not happy, then we move on to the third line therapies. And these are the therapies, I understand, that aren't available for you. I don't know what it would take to get them to Africa. Especially, I think what would be most helpful is the onabotulinum toxin or Botox, because it's so easy to administer and so easy to do. And I think that could really be a game changer too. The other things are neuromodulation, which is a tibial nerve stimulation, stimulating the nerves that go up to the pelvic plexus to get it to calm down. And then sacral nerve stimulation, which is implanting something close to the sacral nerve root. And again, all of these are getting the bladder to calm down. So let's look at these here quickly. The first one, again, onabotulinum toxin A. It's an in-office procedure. It's cystoscopy. You're a urologist, you know how to do cystoscopy. We go in with a cystoscope and a little needle, and you inject a little bit of the medication evenly throughout the bladder. You can see the template here. The starting dose is about 100 units. But you dilute that into about 10 cc's, and it's 10 injections, one either 0.5 cc or 1 cc per injection. So you're putting 10 little sticks throughout the bladder, or 20, depending on how you want to do that. Once it's instilled, it lasts about an average of 6 months. So Botox wears off, but the patients then come into your office twice, maybe 3 times a year to have this done rather than being on a medication on a daily basis. When we do it in the office, we put a little local lidocaine slurry in the bladder and allow it to coat the bladder, let them sit there for 20, 30 minutes. So it really is tolerated very nicely in the office. With the FDA approval trials, there were some patients who really responded even to the starting dose of 100 units, such that it quieted their bladder down so much they couldn't void. And if that happens, then they go into retention, then they need to catheterize themselves. But the reality is the patients who went into retention with very few and far between, 6% retention rate, and then those who did, they catheterized them for, on average, a few days to a few weeks. So that's the main experience that we see. So it doesn't happen very often, really. And we also saw with the FDA approval trials some urinary tract infections around the time of the procedure. They had quoted as 13%. So we do make sure that patients have a clear UA before we do it and cover with them prophylactic antibiotics. We don't see this high rate here, at least I don't clinically, but this is what was seen in the FDA approval trials. So it's really a very nice option for patients and they really like it. The next one is tibial nerve stimulation. So you're putting a little acupuncture-like needle down behind the ankle bone. You can see in her ankle is propped up on a stool there, and the acupuncture needle is in there, and it's hooked up to this machine, which stimulates that needle, which sends a signal up the leg and to the pelvic plexus. And a little bit of stimulation changes the way the nerves perceive what's going on to get that bladder and the whole pelvic area to calm down. The way this was FDA approved is with a specific regimen. And so this is why the regimen exists the way it is, so that the insurances will cover it. But what we don't know is if we do different regimens, will it still work? And that's where some of the newer technology is coming in. The regimen is the patients come to your office once a week for their 30-minute session for 12 weeks. And whatever benefit they've gained after the 12 weeks, they come back once a month thereafter to maintain that benefit. There really aren't adverse events. You're putting a tiny little acupuncture needle down there. Very rarely have we seen a little drop of blood or a little bruise, somebody maybe that's on some aspirin, but nothing really. And what we see is really pretty good efficacy in the patients who do respond, where it's about 70 to 80%. But, and then as long as they keep doing it, we've seen maintenance of that. As long as they keep doing it once a month. But there's only been one head-to-head trial that's done with some medication, and it was done with tolterodine, which is Detrol LA, 4 milligrams once a day, which isn't a whopping anticholinergic dose. I will tell you, if you don't have that one in Africa, it probably compares maybe to oxybutynin 5 to 10. So it's not a huge dose, but the patients had the same effect with the PTNS as they did with the medication, but they liked the PTNS better than the side effects of taking the medication. And that's what this trial showed. But because of that, we think of this really for more of the mild patients, mild, maybe moderate patients, but patients who have severe OAB, urgent incontinence, don't really respond well to this. It's not enough when it's done in this regimen. The problem is it's dependent on coming to the office, right? And many patients, they can't do that. They have lives that don't allow them to come so often to the office. And so the therapy that's being developed is now an implantable device. This little lead gets implanted into the ankle, right where that needle would have gone, just with about a 2-inch incision is made, and then this is implanted right next to that posterior tibial nerve. Then it heals, and then they wear this ankle bracelet like this cuff that goes around the ankle right over the site, and it turns that stimulation on. It turns the device on, off, up, down, so the patients can do their own sessions and do them at home. So the other aspect that we see is that if they can do them at home, they can do them more often. And so if they do them daily for 30 minutes, does that make a difference with respect to what type of patients can maybe respond to this therapy? And what we've seen so far is yes. We see great efficacy, greater than 50% improvement in their OAB symptoms, And what we haven't seen in other tibial nerve stimulation trials is a 30% dry rate. So it's working on patients who actually even have urge incontinence, and 30% are actually getting dry. So this was on the preliminary feasibility trials here at the University of Washington. I'm starting or a site on a multi-center international trial looking at using this. I've implanted several of them already in patients who are doing really quite well. So it's an exciting thing, low risk thing. It does require a little surgery, but it's this very small thing that gets implanted in the ankle, which is so easy to do. So from a risk standpoint, is extremely, extremely low. So doing this in something that would be a low resource setting where patients don't always come back as well, not a lot can go wrong with this. And so, I mean, the site could get infected. It could be problematic in that way and have to be removed, but it's such a tiny little thing. So I see this as helping in to get this form of neuromodulation out to patients who otherwise can't come to big centers or don't live close to big centers to get the therapy. Another form of stimulation is this device. It's called the FemPulse, and it's like a little diaphragm or a pessary, if you want to say. It's like a vaginal ring. It's only 2 inches in size, and the woman puts it up in the vagina and sits it up next to the cervix. And you can see the little electrodes that are on the ring there. Those electrodes that gets turned on, and the woman wears this all the time, just like when she wears a pessary or maybe an S-string device or some other things in the vagina or a diaphragm. And it's stimulating all the time behind the scenes. And it's also meant to be for overactive bladder, urge incontinence. So the initial feasibility studies, I've been part of those here at the University of Washington. We've done 2 initial feasibility studies so far, just looking at the safety aspects. And it looks very safe. And we're embarking on our 3rd large, bigger, multi-center trial for which I'm the main site here. To really look more at the efficacy and what can this do for patients, but it looks very promising. Again, this concept arose out of the idea, how do we get neuromodulation to patients who live in more rural communities or maybe countries, resource poor areas, and make it very convenient for them. So, and with low risk, that's where this came from. So I see this as something for the future. So keep an eye out for this. So now we'll move on to sacral neuromodulation, right? So this is placing a little electrode down by the sacral nerve root and then implanting this whole lead with the wire and then this generator. If you see this picture here, the electrode goes down through the S3 foramen. The wire comes across the patient's back and it gets hooked up to this generator. So all that hardware gets implanted. This has been around since 1997 in the United States. We know it works well. There's lots of long-term efficacy studies that are available. It works for overactive bladder, urgency, frequency, urge incontinence, but also this concept of non-obstructive urinary retention. The pelvic floor muscles and all are so tight, the patient can't relax enough to generate a good bladder contraction and efficiently void, or we call this Fowler syndrome. And it's also FDA approved now in the United States and in Europe for fecal incontinence. We see it work nicely for that as well. The trick to this surgery is implanting the lead. Here's a picture of the lead here, right here. This part right here in the lead that gets implanted deep into the pelvic area is this part here. It shows 4 little electrodes that are on there. And it goes in through this needle stick. This goes through the S3 foramen, and here's the S3 nerve root. And then through that foramen, we're passing that lead through it and depositing it through here. Then we tunnel it across the back and then attach it to a generator that actually makes it work, or the pacemaker part. But the finesse of this surgery is really implanting the lead appropriately along the length of the nerve so all the contact points can be effective. It's an outpatient procedure. We do it under IV sedation generally, or some local. Some people do it under general anesthesia, but it's not needed. And often we do a trial phase first to make sure it's going to work before we implant everything. The newest generations of these are these 2 products here. and we used to have just fixed batteries. When they made the battery smaller for the generator, then it only lasts 3 to 5 years. So even though the lead is implanted down by the nerve and it's working well when you stimulate it, the generator would lose its battery. And so the pocket where the generator was in the upper buttock would have to be removed and replaced every 3 to 5 years. Now they have rechargeable options. They're much smaller. This is the rechargeable option here, and this is the rechargeable option here. They're much smaller and rechargeable such that they last up to 15 years and maybe more. So the patients don't have to have an obligatory surgery every 3 to 5 years just to change the battery. With this device here, you can see here's what gets implanted. The lead gets attached to that, but this little key fob is what turns it on and off and up and down and changes the parameters. So this is what communicates with it. So the woman holds this and then she can click through to turn it on and off as needed. This is the recharging pad, and it gets recharged about once every few weeks. So it's really nice. And the other aspect is it's MRI compatible. The prior devices, you could not have an MRI with the device in. It hadn't been proven to be safe. These are proven to be safe. So big advancements in the area of sacral nerve stimulation. But now we want to look and see what other advances are happening. So the idea is it's still a lot of hardware that's getting implanted, and whatever hardware is implanted in a patient, things can always go wrong with that hardware, right? So how much hardware do we really need to implant in order to still stimulate the nerve effectively to treat the patient? Well, you see this picture of all of these pills here, average size pills, and that little metal device there, that's the lead right there. Through that same needle stick that goes through the S3 foramen, just that gets implanted. That gets pushed down the needle, the foramen needle, and pushed into place, tested first, and then pushed into place and deposited there. And then it works by an external device that the patient wears in her underwear, a little round device up around that site, and that actually communicates with it. And so the idea is, doesn't have to be on 24 hours a day, 7 days a week. Maybe she does 1 hour sessions or 2 hour sessions every day, every other, whatever the patient really needs. So this is really new, exciting technology that we're involved in a trial here as well. Again, thinking again, when someone's in more of a rural area or a low resource area, and they have a lot of hardware implanted, a lot of things can go wrong. If we can minimize what's implanted, less complications can occur. And if they're out in the middle of a rural area and they don't need urgent referral to come into the main center to be taken care of. So here again, our AUA SUFU 2019 guidelines. The patient education was first, our pharmacological management or drugs next, our third line therapies. Well, there is a fourth line therapy, but associated with that is a high risk. And this is when patients don't respond to any of these type of therapies thus far. This is the augmentation cystoplasty, urinary diversion, right? Where we're taking a piece of the bowel, opening it up, open up the bladder, take the bowel like a piece of quilting and sew it onto the bladder to make the bladder bigger. The whole point is to make the bladder bigger, increase the bladder capacity, and also give the patient a low pressure reservoir, interrupting some of those abnormal coordinated detrusor contractions too. So it's a big surgery. It's not embarked on lightly. We don't need to do it very often anymore because of the advances that we have in our third line therapies. These are just a list of some of the complications that can happen from those types of therapies, from the surgeries, besides the surgery itself and complications intra-op. But many times there's a need for chronic catheterization afterwards, whether you have an indwelling catheter or doing intermittent cath, which is what we always encourage, 40 to 60%. And then it can actually fail. They can still have problems after having done this procedure. And interestingly, people who have idiopathic detrusor overactivity, as opposed to neurogenic detrusor overactivity, that's what the N stands for. So patients that have neurogenic bladders usually respond well to this therapy. But people who have idiopathic, like we don't know what the underlying problem is, and we're doing this big surgery for you, only about 45% of them actually, or 45% of them fail. Only about 60, are successful. And that just leads us to not understanding why are they having these abnormal bladder contractions, and what other factors, multifactorial factors, are contributing to their symptoms that we're not addressing with this surgery. You can have a lot of metabolic disturbances by having bowel attached to the bladder, right? We know that, and also just missing that piece of bowel, mucus accumulation in the urine, which then also is nidus for stone formation. And then again, you can have, it's up to 10% perforation risk because you've lost some sensation in that bladder, which can be an acute abdomen. And then the risk of malignancy down the road. So they always need to be under surveillance with cystoscopy to make sure there's not an occult malignancy that develops down the road. So again, overactive bladder evaluation treatment, the history and physical and UA are mandatory. Post-for residual fluid diary symptom questionnaire is helpful. Urodynamics, cystoscopy, imaging, just for the complex patients. Treatment algorithms, 4 categories: behavioral therapies, that's diet, exercise, retraining. Medications is the second therapy. Neuromodulation, PTNS or SNS, and onabotulinum toxin are the third line therapies. And fourth are pretty big, augmentation, cystoplasty, or I didn't mention urinary diversion. You could do a cystectomy and a urinary diversion. Those are pretty aggressive and for select patients only. So now we're going to move on to the stress incontinence, and just doing a time check. For the stress incontinence, there are a couple of different etiologies. We think about intrinsic sphincter deficiency, urethral hypermobility, or this integral theory, loss of ligamentous support. The intrinsic sphincter deficiency is where the sphincter itself is lacking. And you can see clearly in this picture here, the sphincter is nice and tight and the urethra is closed in this one. And here, the sphincter is not tight and certainly not here. And the urethra is wide open. And so with that, of course, the woman coughs and the urine just comes out. Vaginal estrogen is very important in this scenario and really helps reestablish the urothelial lining in order to improve the quality of the mucosa and to give more cushion there. That's one thing. Urethral hypermobility, that's where they've lost support around the urethra. And you can see this is an obvious example where there's a tear on this picture on the right in the pubocervical fascia. So now when she coughs, that bears down on the urethra, it moves the urethra. If it was torn on both sides, it would move it evenly down. And you see that movement of the urethra when she bears down. You see that through the vagina. And she's lost that coaptation in the back. She doesn't get the coaptation from bearing down against this nice little hammock, and the urethra stays open. So that's urethral hypermobility. And the third is the integral theory, as defined by Olmsted and Petros. And it looks at the pubourethral ligament that runs around the urethra and causes this dynamic kinking, holding the urethra in place such that when there's a cough or a valsalva, it causes some dynamic kinking at the urethra that stops the urine from coming out. And when the pubourethral ligaments are lax, there's no support at that mid-urethra and allows the urine to come out. The truth be told is most women have a combination of these, but which is the predominant factor? For the AUA SUFU guidelines, these were most recently updated in 2017. So we have another look that's coming soon. But here, the mandatory is, again, similar history, focused physical pelvic exam, cough, stress test. You want to document what she's doing, have her cough, and did you see her leak? Now a post-void residual is on the mandatory list, and then a UA. What's helpful? Fluid diaries, validated questionnaire. And then again, just as before, in a straightforward index case, you don't need to do urodynamics, cystoscopy, and imaging. It's for refractory, complicated cases. So here we are for the evaluation. And then here is the treatment. Again, the AUA guidelines that you can get on the app. On the treatment, there's non-surgical and surgical. For the non-surgical, we have pelvic floor exercises. If they're lost support, the woman can do some exercises to recreate some of that support herself. That's what's happening over here on the right side. If she's not able to recreate that support herself, then the next thing would be to think about is a vaginal insert, like a pessary. That's actually a continence pessary. Not all pessaries help for incontinence, but these have little bumpers on them, as you can see, that sit underneath the urethra. So when the woman coughs, it bears down the urethra on that bumper and stops the urine from coming out. Or other vaginal inserts that are tampon-like in nature can be helpful. If those things aren't working, there are no other real options for stress incontinence. The next options are really surgical. And the guidelines say we have bulking agents, we have midurethral slings, pubovaginal slings or fascia, rectus fascial slings, which are bladder neck slings, not midurethral slings, and then Birch-Kopel suspension, which is a bladder neck suspension procedure. So let's take a look quickly. I realize you don't have urethral bulking agents either, is what I understand. And I don't know what it would take to get them in Africa, because I think they would also help many of your patients, especially with the advent of a newer one that's come out called Bulkamid. So what they do is you go in with the cystoscope, you can see in the picture on the right-hand side, and with a needle, you inject under the mucosa at the level of the bladder neck some substance that plumps that urethra up. So you can see the wide open urethra here, and it's been now plumped up. So you can appreciate there's coaptation and more strength there. The first three products are permanent products, and they're used today, but there's a newer one on the market called Bulkamid, which is just FDA approved in the United States just a little over a year ago, but has been used widely in Europe and looking like it lasts a bit longer. The problem with these urethral bulking agents are they're unreliable, they're unpredictable. We put some in, some patients it helps, other times we put it in and it looks beautiful and it didn't help. We don't always know why, and sometimes we put it in and it puts them in retention. So the literature would tell us really a third are dry, a third improved, and a third fail. So that's not really great odds. And they often require repeat injections. Even if it works well for them, they come back a year later and you've got to do it again. And it's all permanent material. With the Bulkamid, it's made out of a different type of substance. And what you inject and what you see right away is what you see down the road. And there's good published 5 to 7 year data now in the European literature showing that it actually lasts. So we're really excited to start using this at the University of Washington. We haven't started yet, but we're excited about that. One of the clinical trials that we're doing here at the University of Washington too is similar in that we're putting little balloons up at the bladder neck. Oops, sorry about that. Up at the bladder neck, and you can see these balloons, and it gets injected with this trocar here, and then it's attached to this device here that gets buried into the labia. It's like a little port, and you put a little elma cream or a little numbing cream over that, and you can stick a needle in, so you can blow the balloons up more, or you can deflate them if needed. So the idea is to put that coaptation at the bladder neck, but then being able to adjust it. So this is going through a trial right now for FDA approval in the United States. It had been used in Europe as well. So we'll have more to talk about this later. And for the other surgical treatments, just real quickly, we have the retropubic suspension procedure, which is the Birch-Kopel suspension, which I think you're most familiar with. It's grabbing some of this periurethral tissue here and pulling it up to Cooper's ligament to give the urethra at the level of the bladder neck a little extra support. The pubovaginal sling is taking a piece of rectus fascia and then making a sling out of it and bringing it down in the vagina and slinging the urethra with it. And then the third one are the mid-urethral slings, which are the mesh slings, retropubic and transobturators. So I just want to make this big point. The Birch-Kopel suspension and the pubovaginal slings are very much bladder neck procedures. The mechanism of action is at the bladder neck and is meant to hike the bladder neck up. Whereas the mid-urethral sling, relying on that integral theory, is reestablishing the pubourethral ligament here at the mid-urethra, allowing for kinking to happen with the Valsalva maneuver. So there are different mechanisms of action here. This is just a study to show where are we in our literature looking at the longevity of birches versus the rectus fascia autologous pubovaginal sling. This was called the SISTER trial, a randomized control trial that was done by one of our academic networks. And it looked at the results of these two over 2 years and then 5 years. And what they found was that the sling, autologous fascial sling, did better than birch at 2 years. 66% of the patients were still happy compared to 49%. But when they carried it out to 5 years, which if you're going to under a big procedure, that's not very long. Look at the results there, 31% versus 24% success subjectively by the patients. So that's really not great odds when you look at it overall. But when we look at the midurethral slings, we see better longevity. Just real quickly, the midurethral sling started with a retropubic approach. You can see the mesh going behind the pubic bone, running around the urethra and back up again, coming out stab incisions in the abdominal wall. This was the first one that was developed. It was great, it works well, but there were rare serious complications with the trocars passing blindly behind that pubic bone and hitting the bladder, hitting bowel, hitting large vessels such that patients bled and died. So those are very few and far between, but they did happen. So then people started thinking, well, how can we still sling the urethra at the midurethral area without getting into the retropubic space? And that's how the transobturator was developed. Instead of going through the retropubic space, it goes through the transobturator space, the transobturator foramen or the obturator foramen. And then it comes out stab incisions in the thigh. So this was the second generation developed in 2001. It avoids the retropubic space, but now there were some rare complications with problems with the inner thigh, bleeding and pain and so on and so forth. So these are the two that are called the full length slings. And the third one that's come about now, looking at how can we actually do it so we don't have to come out the thigh. And that's where the single incision sling comes in. It has hooks at the end of it, and it stops at the obturator internus muscle, hooks in at the obturator internus muscle, rather than coming all the way through the obturator foramen. That's what the purple pieces are there. It's showing too that it's not coming all the way through and through the skin. So it is a single incision in the vaginal area and meant to go in the same place as the transobturator, just not all the way through. So when we look at these, here are the pictures of what they look like. The retropubic with the trocars. The transobturator had helical trocars to get around the inferior pubic rami to go through that obturator space. And then here's a picture of the mini sling or the single incision sling with hooks on the end. All of them are made out of the polypropylene mesh monofilament type 1, so they have good sized pores for tissue ingrowth. And they're all meant to be in a tension-free manner underneath the urethra, but they are tensioned differently between these three products. You need to learn how to do that. They're done in an outpatient basis, takes about 10-15 minutes to do. The patients go home the same day and are really very happy. So they work very well, so much so that they really are considered the standard of care for surgical treatment for stress incontinence today for patients that have predominant urethral hypermobility, considered the gold standard. And this is by our American Urogynecology Society, as well as our SUFU and AUA societies. In spite of all of the things that people are concerned about, the use of mesh in the vagina, they do the best and have the lowest risks associated with them. Here is a 17-year study showing great success with the midurethral sling at 17 years with 91% objective cure. They didn't leak when they coughed hard, and 87% subjective cure. So the patients were happy. And out of those 90 women over 17 years, only one of them had a problem with the mesh, a little mesh exposure. So those numbers are much better than the ones I just showed you from the sister trial, describing the birch at 5 years and the pubovaginal sling at 5 years. So this is the midurethral sling. Trying to advance. Sorry. It's not advancing for me anymore. I don't know what just happened. There we go. Okay, so what about the single incision sling? So these again are the new kid on the block. So now we have good long-term data on the single incision slings as well, 3-year data and even out to 5-year data that shows again comparable efficacy. 90% to 88% compared to the transobturator. So this was a randomized control trial that was comparing it to the transobturator. And this was an FDA mandated trial. So you see those numbers are much higher again. And with the single incision sling, then it is just the single incision dissecting up into the behind the inferior pubic rami, and then putting the trocar in there on either side with the anchor there. So no other dissections or incisions. So again, SUFU is the standard of care worldwide for the surgical treatment of stress incontinence. And it's because it's due to its very favorable risk-benefit ratio. Not only does it work well, but the risks associated are really quite low. So besides, unlike what you see in the literature on early data on prior products, not the generation products that we have today, they did have problems, but we know in trained hands, it takes proper training for people to know how to use the mesh appropriately in order to do it safely. And in 2021, the mid-urethral sling is still the most common procedure for stress incontinence. And in Europe, that's the same thing, in spite of the things that have happened in Britain with a pause and all of that dealing with the mesh. So the current guidelines for the EAU was revised in 2018, so just a few years ago. The preferred surgery is the MUS, mid-urethral sling. If you can't do an MUS, then a pubovaginal sling. And it's still the most frequently thing done in Europe. So evaluation summary is what's mandatory here again, history and physical, pelvic, and a UA, just like it was for overactive bladder patients. But here you also need to add a cough stress test to document they leak when they cough or sneeze, or and then a post-void residual is on the mandatory list. Helpful fluid diary symptom questionnaire. And for complex patients, those are the only ones we need urodynamics, cystoscopy, and imaging. Treatment fall into the non-surgical category. Really, it's improving the muscle strength inherently with Kegels, or using a vaginal device like a pessary. And if those don't work, we move on to the surgical things. The urethral bulking agents, those are a great option, predominantly for people who have more of the intrinsic sphincter deficiency issue, although with the use of Bulkamid, that's also being challenged. The mid-urethral sling is really the standard of care, as I said, and with the single incision sling really making a great showing when it's looking at now some comparative trials. For more complex patients, the pubovaginal sling is still a very good option. For more complex, patients where you really want more coaptation at the bladder neck, they've been operated before. And the Birch, if you're going to do an open procedure, the Birch is an open procedure, right? You can't get to it unless the belly is open. And so if you're going to do an open procedure anyway, you could consider adding a Birch, but I showed you what the long-term data is. It's not so good. So it might behoove you to think about a different option for the patient to give her some more longevity to the repair. So I know we are about out of time. We do have 2 cases. I don't know if these were given to me. If you want me to go through these still, I'm happy to do it.
Yeah, kindly go through for me. Thank you.
Absolutely. So, I just thought this would be more open for discussion. I'll just present the case and a little bit of my thoughts about it, but if people have thoughts too. So the first case is a 38-year-old woman. So she's gravida 2, para 2, right? Had 2 children and they both were vaginal deliveries, but the last one needed some help with the vacuum assisted device. So she's had urinary leakage since that time, and it's presumed to be stress incontinence. Reportedly, she didn't complain of any urgency incontinence. She was treated by putting on a good Kegel regimen and then given some solifenacin, which is the anticholinergic OAB product. She did actually pretty well with these 2 things, and now tries to come off the solifenacin and finds she's leaking again. So what's the problem here? The first thing was, what's likely her true diagnosis? So, I mean, she presumably had stress incontinence, gave a history of leaking when she coughed, sneezed, and the Kegels helped her with that. We do see, the incidence of stress incontinence increases with each additional vaginal delivery. And if the vaginal delivery is complicated, that increases it even more. And we know that this was complicated because she needed a vacuum assist. And we know the pressure with the vacuum assist oftentimes it makes the baby come out a bit faster. And I think sometimes there can be more damage that's done. But, by and large, the vacuum was presumably used for a reason because the baby wasn't coming. And so that's hard to say, but we do see with more complicated deliveries, right? The incidence is increased so clearly. So it sounds like if the solifenacin is really taking care of her symptoms, that she does have an urge incontinent component. Maybe she didn't identify it right away because she was having such bad stress incontinence that sort of overshadowed the urge incontinence that she was happening. And now that the stress incontinence has resolved with her good Kegels, and she tries to come off the solifenacin, she notices now the urge incontinence. That is likely what is happening here. So her true diagnosis is that she had mixed incontinence. And the appropriate treatment then is really the algorithm for the overactive bladder urge incontinent patient, looking at the dietary issues, pelvic floor exercises now, but for urge suppression, teaching her how to do that, and the medications, and then some of the other neuromodulatory things if possible. Can she come off her bladder medications? Well, we don't really see that, and what we do see that if patients have made other changes to their lifestyle that affects their bladder, right? And so they did some things, maybe they aren't drinking as much coffee anymore, or they are monitoring what they're drinking. They're drinking, a normal amount, which is about 2 liters a day. They used to be drinking 4 liters a day. So, or maybe they've lost some weight, or they've done some other kinds of things. Well, then maybe they don't need the medication anymore. Truth be told, they should have done some of those things, certainly the easy dietary things first before even starting the medication. But if they didn't, and if they haven't made any other changes since starting the medication, there's no reason to think that they should be able to come off the medication if they haven't been doing something else. So the analogy I make is that somebody has high blood pressure, they're put on a blood pressure medication. Well, they still have high blood pressure, but their blood pressure is controlled, right, on the medication. If they come off their medication, they have high blood pressure again. So what the medication does, it controls the blood pressure, but it didn't get rid of why do they have the high blood pressure, what's going on in the first place. So the anticholinergic medications or the bladder medications are the same kind of thing. If you just put somebody on a medication and don't do anything else, and they don't do anything else, there's no reason to think that after a certain amount of time, they can be weaned off of it. Now, if they want to do a trial, there's no reason they can't, but we don't have any evidence to suggest that after 6 months, patients can come off, for example. If you have done some other things, you initiated vaginal estrogen to improve the quality of the vagina. They've been doing Kegels with urge suppression, working with the pelvic floor physical therapist. They did some significant dietary modifications. Well, now maybe they don't need their anticholinergic anymore, and now it's worth a try. So what other options are there besides surgery? I think we just mentioned all of those together. So I don't know if there are other questions specifically about that case, if anybody has thoughts. If not, we'll go on to the next case. So the next case that I was given is a 65-year-old female. So she is postmenopausal. She's gravida 11. We don't see this in the United States. Para 11, all vaginal. My first thought is I would want to do a pelvic exam and see, does she have prolapse, right? So she's leaking urine. She has stress incontinence. She admits to that as well as urge incontinence, gets that urgency. So it's called mixed incontinence. She's been treated the same way, Kegels and anticholinergics, but she's not satisfied. She had a Birch colposuspension done for the stress incontinence and then went into retention post-operatively. The Birch was just done a little too tight and it put her in retention. Well, so now what do you expect? Well, first of all, remember the Birch is meant to help her stress incontinence, not her overactive bladder urge incontinence. It doesn't do anything for that. in fact, if some surgery is done for stress incontinence, and it's done such that it's done too tight or too much, the bulking agents are too much, and the patient's having trouble now emptying her bladder, it worsens the overactive bladder urge incontinence. And sometimes people can even get de novo urge incontinence from our stress incontinent intervention if it wasn't done well, or there are some other things that happened. So what's happened here is it put her in retention. It needs to be addressed, and also most likely is worsening her urge incontinence. So it shouldn't be left that way. The options, though, are what? With a Birch Copus suspension, we do know that it relaxes with time. But does she want to wait that long? How many years does she have to wait until it's relaxed? And you'd give her some time to do that for sure. If it's an immediate post-op retention, maybe a few months, but in the meantime, she needs to catheterize herself and make sure her bladder volumes are never that big so that she's not getting more urgency that's going on. So you don't want to just say, well, you're straining and you're getting it out when you strain, so just do that, because that will definitely just worsen her stress, her urge incontinence. So you'd want to put her on an intermittent straight catheterization regimen. That's much better than a chronic Foley, needless to say. And then at what point would you decide we're going to take it down? Well, that's a conversation that you're going to have with the patient, because if you take it down, she's back where she started for the most part, right? Especially with the Birch. If you've done some type of a midurethral sling, there's some thought about some scarification that happens around the area of the mesh, that maybe that scarification process is enough. But with the Birch, it's a little bit harder. You're getting up there, if you do it vaginally and snipping on both sides at the bladder neck in that pubocervical fascial area to try and release that somewhat. So it's a little bit harder to take down. But that's really what has to happen. So you need to watch her closely. This isn't somebody that you want to go back to her rural area and not see you for 6 months, because she's going to come back with a huge problem. Recurrent UTIs if she's truly in retention, only peeing a little bit up off the top, and it's going to make it much more complicated. So this is somebody you want to watch closely and you need to address. Do intermittent cath for a while, see if it's going to loosen a little bit with time over the ensuing maybe 3 months, see what happens. Is she emptying adequately, even though not perfectly? Or do you need to actually go in and take it down? And then if you need to take it down, then you're going to follow suit with something else. If you thought she was a good patient for a Birch, that means she has urethral hypermobility. Was she a good candidate maybe for a midurethral sling? I think this case was done many, many years ago, so clearly the midurethral slings weren't available then, but they are today. Then she may benefit from that and less risk of retention. Or if you wanted a pubovaginal sling, but the least invasive thing would be a midurethral sling. And then you also have to still address her urge incontinence, right? So you're going to have to go down that same algorithm for the urge incontinence treatment, looking at behavioral things, medications, then think about some of the third line therapy if you had some at your facility. Again, with respect to the third line therapies, I think, I don't know what it would take to get Botox to go to Africa, or if it is available in some areas, but I think that is one that could really help the outpatient practice very well. So, and with that, I'm done with what I have prepared for you. Thank you very much. This is Mount Rainier, which is here in Seattle, one of the tallest mountains. Elevation is 14,400 feet. Many people climb this. It's quite dangerous. I have yet to do it myself, but yeah, it takes a brave person, but it's very beautiful to look at. So with that, thank you very much. I'm very honored to speak to you today, and I hope you've learned something. And if you have any questions, please, Katie can give you my contact information. I'm happy to answer questions through email or whatever people would like to do.
Thank you so much, Dr.
Great.
Sutherland.
Yeah, my pleasure. Any questions?
Any questions from the floor?
It was completely clear.
Great.
Okay.
All right.
All right. Well, with that, enjoy the rest of your.
All right.
I
Thank
guess
you so much.
evening. It's evening for you there, right? So probably late. Time to go to bed. So thank you for having me. It's been a pleasure.
Thank you very much. Bye-bye.
Thank you.
Thank you. Have a nice
Thank you
day.
so much.
Thank you.
Bye-bye.
Bye-bye.